Thank you. I'd like to introduce Dr. TJ Kanheri. So I've been very fortunate to have TJ as my pain fellow at St Vincent's Hospital for this last year. And TJ is a vocationally registered general practitioner. And I just wanted to pass over to him so that he could talk you through his convoluted journey to starting pain training.
Yes. So thank you, Jenny.
The quick version would be
yes,
good, TJ.
Absolutely. Yes, thank you for having me here. So I actually finished my general practice training in 2016. In 2017, started looking around for what I wanted to focus in general practice, worked a bit in occupational medicine, bariatric medicine, and then came full circle got very curious about pain. And I realized that, like, in all of the patient dealings that I had for patients with pain, in particular chronic pain, I didn't feel like I had a very good understanding of what the patient was presenting with and how I could help them out with. So learning more about that sponsored learning a bit more about the new changes in the way we approach pain in pain medicine. That really kicked off this whole journey for myself.
Yeah, it's interesting that you say that, because I came at pain as well not from a I want to do pain medicine, but from a feeling of inadequacy, just feeling as though as an anaesthetist I really didn't understand enough, I didn't know how to treat it properly. And I think that pain medicine really was almost at the point of the barber surgeons probably about 20 years ago, in that there was a lot less evidence, and some of what constituted pain medicine was not the right thing to do, but we just didn't have the evidence for what was the right thing to do. Mm-hmm. And it's progressed so quickly, and the evidence is emerging. And so now there is a little bit of an evidence base around what to do. So it's a very exciting field to be part of. It's not what you'd call a mature specialty at all. And it's great to be part of an immature specialty, an emerging specialty, you'll call it. So what I'd like to get from you, TJ, in essence, is what you've learned being both in the community and in the hospital, what the differences are, and what we can do to make it easier for GPs.
Absolutely. So I think the biggest difference is that hospital admission is typically an event-based admission. So someone comes in with a issue, that issue gets addressed, they might have some more issues along the way, but the end of the hospital journey, usually for most people, is that they get discharged home. So I think hospitals have a very clear goal, which is let's get the patient home. And there's lots of reasons for it: better for the patient, better for the community, reduce risk of iatrogenesis, all the other things there. But I think that drives a lot of hospital-based decision-making. And then there's this thought process that let's get the person home, because after that, they'll be living happily ever after. Someone else can sort out the other medical issues, and that's that. I think the difference in general practice is where that's someone else, and that people come and often following a hospital admission, they have a very well-written discharge summary that has 17 points to address in terms of how to help look after the patient, and then we're stuck with 8 minutes to do what we can in that time period to do what's right for the patient in front of us. The other thing that's different in general practice is that longitudinal-based relationship where we see patients for weeks, months, years, and the relationship that develops from there, which occasionally does happen in hospital, especially with patients that come in numerous times due to various conditions. But it's much more of a driving force, I think, in general practice compared to hospital-based medicine. And I think the thing that can be done to help out is better communication from both parties. So general practitioners calling in when a patient's admitted about various issues and getting a bit of it can be an opportunity to get an update about what's happening with the patient, but also on the flip side, when a patient's being discharged, about what needs to be done, needs to be more effectively communicated to not just the general practitioner, but also the patient in question as well.
I find the differences there, that sort of very longitudinal relationship versus our truncated relationship often, to have some good things on both sides. One of the things that I think as a hospital doctor I can do sometimes is to be a little bit of a circuit breaker. So somebody comes in for a sentinel event, whether that be a medical emergency or an operation, and they meet somebody new, And it can be an opportunity to give a slightly different slant on education, to talk to them differently, present a range of options. Sometimes we have, well, I think on the whole, we have more time within the hospital environment. And so I see that as being complementary to what's happening in the community. Sometimes we can just be that circuit breaker that changes things quite rapidly, whereas I think probably that's more difficult within the community. Do you think that's fair?
I think so. I mean, I think sometimes the hard part is when a patient has an expectation that, having gone to an appointment many times and had the same outcome for it, especially if you're not someone new to them, so that whole dreaded scenario of colleague retiring and then the patient coming to see you on large doses of opioids, there's often a bit of a resistance and pushback saying, well, why are you being difficult, versus my previous doctor was fine and they would give me the script and there was no problem. And I think that's a bit harder to manage in a general practice setting compared to when someone comes into hospital and has someone completely brand new de novo from a different experience coming in and talking. So, yes.
So let's get to the nitty-gritty,
Sure.
TJ.
Yes.
I'd just like to ask you about a few little clinical scenarios.
Oh, God.
And whether how you cope with those now is different to before you came into the hospital system and trained with us.
Yeah.
So, for example, you've got a patient who has osteoarthritis of the lumbar spine.
Yep.
And has been on OxyContin 40 milligrams BD plus some breakthrough endone.
Yep.
And their usual GP is retired and that patient ends up with you.
Mm-hmm.
Now, I know I've only given you a drug history and nothing else, but do you think how you would treat that patient now compared to a year and a half ago has changed? And if so, in what way?
I think so. I mean, I think a year and a half ago, my heart would sink when a patient like this came through. I mean, because I would feel like unequipped to be able to handle the needs of this patient, and I wouldn't be sure if I could really help them out. What I would do a year and a half ago would be probably to continue the script after checking to see there was no patterns of misuse behavior or anything else, a phone call to the prescription shopping hotline, etc. And then probably with a referral to the pain clinic and a silent prayer that they would see the pain clinic sooner rather than later to help me out. I think now what I would do, I mean, all those things are still reasonable, silent prayer notwithstanding, but I would probably also get a bit more of a sense of the patient that's in front of me and also the medication they're on. For this one, I'll focus on opioids and medication mainly, but of course, a really good framework is the psychosocial biomodel or the biopsychosocial model for making sure you see the person as a whole in terms of the issues they may have, both from a biomedical, psychological, and social perspective, because all these things interplay. With this patient, they've been on OxyContin 40 milligrams BD plus some opioid endone breakthrough. Let's keep it simple and say 20 milligrams in the course of a day. So that's a total of 100 milligrams of oxycodone or, oxycodone SR per day. One really useful tool for risk stratification is to convert any opioid a patient is on into what's an oral morphine equivalent. So there's plenty of tools available to do that. The Faculty of Pain Medicine has an app, which is great. So you just plug in the numbers, the dose of opioids, and it'll tell you the numbers that they're on. But oxycodone is a 1.5 times, equivalence rate. So for that patient that's on 100 milligrams total of oxycodone or oxycodone SR, that works out to be 150 milligrams of oral morphine equivalents. There's lots of different risk stratifications for morphine equivalent dosages, but as a general rule of thumb, there's two ones that are used a fair bit. More than 100 milligrams is definitely red zone, no question about it. But I would say over 60 milligrams oral morphine equivalent is actually a more reasonable red zone marker, especially if the patient has other comorbidities like such as age or other conditions or anything else.
It's really the tipping point, isn't it, where you start going from minor increases in side effects to quite rapid increases in side effects over about 50 to 60 milligrams.
100%. And also the other thing is it's often with the patients, they've been on this medication for a long time, but as they age and have more medical issues as well, of course, then the chances of those side effects are much more pronounced as well, which is often a bit of pushback from patients when we have this conversation. It's like, I've been on these drugs for 20 years and have problems, so, why are you? But I mean, it's a really important thing to look at in terms of risk stratification.
It's almost like they're aging into side effects.
Yes, sir. Yeah,
and that's one of the ways I sort of explain it to them was at 60, you might not have had side effects from these, but actually your dose needs to reduce as you get older. So you're aging into these problems.
Yeah, and absolutely right. And even if they're not aging into it, they might have had side effects we're unaware of. So things like for men, reduction in testosterone, for example, or effects on mood, effects on cognition, effects on memory. All of those sorts of things can be side effects of opioids. And patients may be unaware that they've been having side effects. They might just think that their mood's bad for other reasons, whereas it's from the opioids might be contributing to it. Once I had a sense of the opioid dose that they're on, I think for any patient pretty much above 60 milligrams, I think it's quite reasonable to refer into a pain clinic and get advice and a multidisciplinary team action. I would also look for the 5As of opioid analgesia. So this is available through the ACI website if anyone's interested. But basically it boils down to activity. So what sort of what the patient is doing right now on a day-to-day basis, how far they can walk, how far they can sit, stand, all those sorts of things, and whether they need help with activities of daily living like cooking, dressing, etc. The next one is analgesia, which we'll talk about in a sec, and go into a bit more detail what that represents. Third is looking for adverse effects, so side effects from medication. The fourth one is aberrant behaviors. So this is things like losing scripts, coming back early for refills, doctor shopping, all those sorts of potential red flags that might point to something beyond using opioids for chronic pain that might be a suggestion of opioid use disorder. And the fifth one is affect, so checking their mood and seeing that how that is and how that interplays with everything else. With the analgesic effect, often patients will say things like, if I don't take my X drug, I can't get out of bed. And that doesn't necessarily mean that that's having an analgesic effect. They might be using it for other purposes, or they might even not recognize that it's actually the time after they wake up that's the beneficial thing rather than the medication they may be taking. And a really good way to tease that out is to talk to them about the drug in question, ask them what they think it's doing, how long, when they take the medication, what is their pain like before taking the medication, what's their pain like after, how long the effect lasts for, because that can give you really good clues in terms of the effect the opioid is having, if any, and also provide options for treatment in terms of if the opioid's only lasting for 2 hours, for example, then, is there something else that we might be able to fiddle with or change the timings or whatever the case may be?
I think one of the adverse effect issues that we've gone through quite a few times, TJ, is to find something that matters to that particular patient. So for young men, for example, I will do a testosterone level and show them that it's reduced. And for most young men, that will be quite a sort of salient moment. The implications of this. Yes. For somebody who's had depression, to say to them that it might make their depression treatment resistant or worse, and we know how terrible a problem that is, and they don't want to go there again. So that can be very important to explain to them. Somebody's had fusions and they're worried that their bones are like butter and they might fall apart, to talk about the association with osteoporosis. So just teasing out what it is that's going to matter most to those patients. And I think that's quite a good way to frame the discussion about adverse effects.
Absolutely. And it's much like with smoking, where it's often talking about smoking cessation. It's very easy to talk about abstract things, but if you really hone it into the here and now things that are affecting the patient, so someone with significant financial stress, looking at the cost of smoking, in much the same way with opioids, tailoring the discussion to the person in front of you, the problems that they're having, and showing them links in the opioids that they're taking, some of the effects that they're having, and saying that these two things may be related, can be a really, really powerful driver for change. And I find that in my experience, I've been very pleasantly surprised at just how much people are happy and willing and eager to change. Often people feel trapped in the opioids that they're in because they're still in chronic pain. They think this is the only thing that helps. They've gone to their doctors in the past and all that's happened is the doses have gone up, and everyone's stuck in a situation they're pretty unhappy about. And offering a patient a way out can be a really powerful thing in terms of reducing opioids and discussing what effect that'll have on their pain levels, etc.
I think one of the problems that we hear about quite frequently and is very legitimate is issues with general practitioners who have a patient in front of them, they know that the waiting list for their local chronic pain clinic is months. And I remember you talking about learning what you might do in a circumstance like that. Would you like to elaborate?
Absolutely. So the one thing I did wish I knew earlier was that help is often just a phone call away. Getting in touch with the local tertiary hospital and asking to speak to the pain registrar or pain fellow there is a really useful way to get a little bit of phone advice. Sometimes we're a bit limited in terms of specific nitty-gritty advice we can provide over the phone. What we can also do is facilitate this patient being seen much quicker in our pain clinic. With pain clinics, the nature of the job often, at least in the clinics that I've worked with, there's often cancellations and other things that happen. And so even if a pain clinic's fully booked out, it means we can usually see someone that's more of a priority much quicker, but we have to be aware of them in order to do so. And so calling us and letting us know about the patient, the situation that's going on is a really helpful way to get a little bit of phone advice and in terms of where to go beyond further as well. So that's something that I wish I'd known before.
All right. So one of the other common issues is if you've got a patient who's on opioids already and they have a flare of their pain. I think that's a really common problem that happens in the community. Is there anything new that you've learned about what to do in that circumstance?
Absolutely. So actually, funny you should ask this, Jenny, but when I was leaving my general practice to go into the hospital system, I was asking my colleagues what they would like to see in the correspondence from pain teams. And the most common feedback was what to do when the patient's pain has flared and how do you handle that. And somewhat ironically, I haven't put that in my letter, so I better start. But thanks for reminding me. Anyway, but I think the key thing about it is when a patient comes to you and they have a flare-up of pain, the things that run through my head now are, first of all, has something changed in their biopsychosocial framework? So it can be, of course, is there a biomedical change to whatever condition they have? And of course, we're speaking in generalities here, but quite often there's concomitant psychosocial stresses that are also there. And that's helpful because the psychosocial stresses that are there offer an independent pathway of treatment that don't require any medications or require a different type of medication, perhaps, to the opioids and other substances. So what I would do is, the other thing I would do is sometimes when a patient comes in and they have a flare-up of pain, their distress is being communicated to you. And it's very easy to get caught up in that distress as well. But sometimes it's helpful just to take a step back and kind of get a sense of what exactly is happening to the person in front of us and what's treating it. And often you'll find that if someone comes in with a flare-up of back pain, for example, a question like saying, okay, I get where you're coming from, we're going to definitely help you out with that, but can I just ask, is there anything else stressing you out right now? Something a bit more of a overarching question can sometimes be a really helpful bridge to talk about some of the other things. Some patients won't like that, and then a small education piece about how pain, emotion, and stress can feed off each other and are linked can be really helpful to establish why you're asking those questions. And that can be a good sort of segue again to talk about this a bit more. In terms of nitty-gritty medications, that kind of thing, it depends on what the patient's on right now, but sometimes when a patient has a pain flare up, drilling down into what exactly is flared up or what kind of duration can really provide good insights in terms of how you can help them in the here and now. And often it doesn't mean increasing opioids or other medications. It might mean something like rotating, which we can talk about if we have time, or it might mean something like changing the times of medications, or it might mean instead of having it twice daily, the same amount of drug but 3 times a day, or whatever the case may be. And getting a bit of a sense of how the pain's going can be helpful with that. Yeah.
I think timing is crucial. And in my earlier presentation, I talked a lot about slow release opioids. And I think one of the advantages of focusing on immediate release opioids is that it's much easier to change the timing of those drugs to respond to incidents than it is for slow release, which just burn on in the background, probably not doing much. So that brings me to almost a personal question, TJ. And it's been quite a focus for me in the last maybe 1.5 to 2 years particularly, to just change our hospital into a non-slow release opioid using hospital. And I exclude cancer pain here. What's it like working in a place where we don't use really any slow release opioids for acute pain. Do you think the patients are worse off? And I fully give you carte blanche to say that you think it's worse.
I actually think the patients are better off. And I'm not just saying that because you're sitting next to me and you're my immediate advisor, but yes, but it's because I think there's a couple of things. First of all, like one thing I didn't touch on before, or I did very briefly, is it's often worth asking patients what they think opioids are doing for them. And it's truly remarkable the answers you get. Sometimes people think they're actually treating the pain in the sense of how antibiotics treat infection and all those sorts of thought processes. And so, but with long-acting opioids, I feel like there's a bit more of a sense that this is a chronic, persistent, pervasive condition that transcends the actual medication dose or anything else in and of itself that isn't there with the short-acting opioids. And that, and of course, there's the negative health outcomes. But I actually think that I have not once in the last year wished that I could have prescribed someone a long-acting opioid in any sort of setting, really. Yeah.
It's been interesting how different our pain rounds are now that we're not having patients coming in from the community so much who are already on them. My job is a lot easier.
Absolutely.
The rounds are shorter. Don't tell
imagine.
That to the administration. They might give us other things to do.
Exactly.
But
Yes.
it really makes a big difference.
Yeah.
And yeah.
And I think the flip side to that, though, sometimes patients do come in and they have been on large doses of Targin or Oxycontin or whatever else. And then what do you do in that setting when they've been on those slow, long-acting opioids for a long period of time? What do you do for the person when they're sitting in front of you? And I think these sorts of patients are absolutely fantastic to send through to pain clinics. And I think this is very much what we're here for and what we would love to help you out with. And in the meantime, if you're not sure, because sometimes, as we alluded to before, the wait can be quite long to see a pain clinic and have a multidisciplinary approach. It can be really helpful just to, and I'm fully cognizant that I'm giving myself more work doing this, but just getting on the phone and talking to us can be a really good first step in terms of providing a bit of targeted advice in the short term and then linking them in with the pain clinic in the long term.
Yeah. I think one of the things that I try to teach throughout the hospital is to recognise distress and to just be kind to patients who are on long-term opioids, whether it be for opioid agonist therapy, for drug use or for pain. There's some really beautiful literature showing that medical students feel more and more comfortable as they go through medical school with almost every single condition except chronic pain. And I think that one of the reasons for that is because there's been this large group of patients who come in on opioids, and it makes it's a harder problem to deal with. You're dealing with the patient and their pain, plus you're dealing with the opioids almost as a separate issue. And to try and teach them that kindness, that trying to rip people off their opioids rapidly is not the answer, that kindness is the top thing. Recognising distress is right up there. And then you deal with the drugs, but you have to, as you said, TJ, I think, establish that rapport with the patient and help them to understand that you're there for them. And I think we've been very bad in hospitals on the whole, I would say, at doing that in the past. But we're really trying to make quite a big effort that's the message that we convey to our patients first before we start talking about what they're doing wrong or with their drugs.
Yeah, 100%. And also, I would just add on one small point to that kindness. It's often the situation that a lot of patients find themselves in isn't really anyone's fault as such. I mean, the prescribing paradigm from 20 years ago is very different to the prescribing paradigm of today. And the doctors that prescribed the patients these opioids thought they were doing the right thing for the patient. So I think acknowledging that is really important, because otherwise it can end up becoming a bit of a blame game. Like, Dr. Smith did this to me, and all of those sorts of things. So being kind to the patient, but also recognizing that this is a situation they're in that is a bit outside of their control almost, and is a really good way to kind of create that discussion and talk about where to go from there in terms of reducing opioids in the future.
Well, one of the things I can say over the last year, TJ, that I've noticed about you is the way that you talk to patients is quite different. And
Really?
it's
Okay.
it's fantastic. It's really good. You can see them immediately going, this guy understands what I'm going through. And I think that was happening less at the beginning of your training year and is happening more now. And once you get that, this person understands what I'm going through, then you can proceed. And that's changed a lot, you know.
No, thank
Me
you.
watching you.
Very kind of you to say.
So we might leave it there. Thanks for joining us.